So cirrhosis. What is cirrhosis? Cirrhosis is the end stage of many chronic liver diseases. You can basically think of this as chronic liver failure or end stage liver disease. What happens with all these chronic liver diseases is it causes liver damage, and eventually you're going to get scarring, and you're going to get replacement of your normal hepatic tissues with nodules of regenerating hepatocytes. So these are called regenerative nodules. So you can see here regenerative nodules. And you're going to get fibrous bands which bridge between portal tracts. So this is called bridging fibrosis, and that's all scarring down, damage leading to fibrosis and scarring with regenerative nodules. So your liver function is decreased, and it's going to lead to basically, what was the liver function? Remember, liver function was protein production, liver detoxification of stuff, of drugs, toxins, and secretion of bile. So, many etiologies that I told you of many chronic liver diseases. We can divide the etiologies into three. The first one is hepatotoxicity. So that's basically toxic insults to the liver. So that can be alcohol abuse, can be medication overdose. So you can overdose, or even just medication side effects in general, that can all lead to liver damage. Okay, number two, inflammation. Inflammation of the liver can cause cirrhosis. So that's things like hepatitis, either chronic viral hepatitis, autoimmune hepatitis. You can have something called biliary cholangitis. We're going to talk about all of these different etiologies of cirrhosis later. So hepatotoxicity, inflammation. Third cause is metabolic problems. So that's something like non-alcoholic steatohepatitis, aka NASH, or hemochromatosis. That's too much iron. It's like an iron overload. Wilson's disease. It's like a copper overload. And finally, you can have alpha-1 antitrypsin deficiency. Don't have to memorize all these at this point. This is just a brief introduction. We're going to talk about all of them in a little bit, okay? So we talked about what is cirrhosis. Cirrhosis is basically chronic liver failure, poor liver function. It's due to chronic damage and inflammation with fibrosis. So fibrosis basically means the liver doesn't work very well because it's being replaced by scar tissue. Etiologies of this chronic liver disease is, we can classify into three: hepatotoxic, inflammatory, metabolic. Okay. Now, before we get into clinical features, I'm going to talk to you about portal hypertension. Portal hypertension is resulting from increased resistance to portal flow at the small vessels of the liver. Okay, so this is the portal circulation here. Portal blood usually goes towards the liver, and it's going to branch out, and it's going to get smaller and smaller vessels within the liver. Actually, let's change our pen color here. Then it's going to branch and then connect with the veins, okay? And blood's going to go from the portal vessels to the veins normally. But if there's high pressure here, maybe due to all this scarring, you have scarring, you have increased obstruction and resistance to blood flow in the liver. Blood doesn't want to go that way anymore. It's too much pressure. So it's going to go backwards, as you can see in these red arrows, okay? It's going to be rerouting of blood into collateral vascular channels between the portal and systemic venous circulations. So then that rerouting is going to cause increased blood flow. It's going to cause dilation of these collateral blood vessels. Now there's three collateral blood vessels to be aware of. First one is at the esophagus. It's collaterals between the gastric vein, which is here. This one is the gastric vein, and then the esophageal vein. This is a systemic circulation esophageal vein. This purple one here is a portal vein, the gastric vein. And so if you're going to get dilation here, you're going to get esophageal varices. I told you about those in the esophageal lecture. Remember, you get dilation of the vessels, and then those can bleed and cause massive bleeding and even death. The second area of collaterals is here at the umbilicus. Umbilicus can have collaterals between para-umbilical and then the epigastric. Epigastric are the systemic ones. Okay, so you get dilation of both of these veins, and what you're going to see is something called caput medusa. It's basically over the umbilicus. When you look at someone's stomach, they're going to have these dilated veins. This is again from portal hypertension. Finally, if you look at the rectum, which is right here, again see dilation between collaterals. This one here is the superior rectal, and then the systemic circulation ones are the middle rectal and then the inferior rectal. So these are easy enough to remember. Superior rectal from portal, and then medial rectal and inferior rectal from the systemic circulations. And what's going to happen when these dilate is you're going to get hemorrhoids. So that's what hemorrhoids can come from. Okay, so esophageal varices here from esophageal vein and gastric vein collaterals. Caput medusa, which is from the periumbilical and the epigastric collaterals. And then finally here, hemorrhoids from the superior rectal collateral and then the middle and inferior rectal collaterals. So the way you treat this, I already wrote it all down. But anyways, the way you treat this is, I told you there's increased resistance here due to scarring, right? All this scarring and this stuff. Basically, you can treat it with something called TIPS, transjugular intrahepatic portal shunt. It's a long name, so I just call it TIPS. You're basically creating a shunt, a new path between your portal vein and your hepatic vein. Okay, it's kind of like in life. If you meet some struggle, sometimes it's nice to push through and have that grit. But sometimes you can just be smart and you create a new way, you create a new path, and that's what you're doing in TIPS. You're creating a new way, a new path. Right here, there's low resistance because you made this path. There's no scarring in this path. Okay, and now your blood, instead of having to go backwards, as you can see here, instead of going backwards on this picture on the right, your blood's going to be able to go forwards because now you just reduced all that pressure. You're going to reduce a lot of that hypertension, and reduce that blood flow to the collateral veins. It's going to be reduced dilation. So that's TIPS. Alright, so now we can go into clinical features of cirrhosis. So clinical features of cirrhosis arise from portal hypertension and failure of normal liver function. Again, portal hypertension arises due to all that scarring, increasing resistance to blood flow inside the liver. And failure of normal liver function can include both failure of detoxification and metabolism, and what was the other liver function? Other liver function was, remember, protein synthesis. So portal hypertension. It basically leads to congestive liver disease. I already talked about these portal systemic shunts. Remember, where were they? When you had the esophageal varices, you had the umbilical varices, and then you had the internal hemorrhoids. The other things that you have are enlargement of liver and spleen. Again, you have buildup of all that blood in the liver, so it's going to become congested, it's going to enlarge. You're going to get abdominal pain. Again, it's just that it's all that increased pressure in the abdomen is causing pain. And you have ascites. Ascites is buildup of fluid in the peritoneal space. So you have all this congested vessels around the liver, and so fluid's going to come out. Remember, this peritoneum is this whole sac. So fluid's going to come out of those vessels, and it's just going to hang out in this sac, and it's going to cause something called ascites. You see that this basically is a pool of fluid in your peritoneal sac. Okay, next is failure of detoxification and metabolism. So, first of all, UGT doesn't work. What happens there? You get hyperbilirubinemia, you get jaundice. Okay. The other thing is that you can have high levels of estrogen, because normally you metabolize the estrogen, but again, your liver is not metabolizing anything very well. High levels of estrogen cause a variety of symptoms in the patient. You're going to get something called spider angiomas, which you see on the right. It's just very spidery little red discoloration on the skin. You get palmar erythema, that's redness of the palms. In men, too much estrogen causes hypogonadism, and it causes gynecomastia, which is like developing of breast budding in men. And in women, you get amenorrhea because you're messing up the menstrual cycle with too much estrogen. So remember all those clinical features from estrogen. Then you also get hepatic encephalopathy. What this means, encephalopathy is a disorder of the brain, right? It's mental status changes, and you have something called asterixis. That's the Flappy Birds thing, where you move the hand and it looks like a flappy wings. Hepatic encephalopathy arises due to buildup of ammonia. Because what normally happens is the liver, usually you have urea, liver turns it, you have pneumonia, and the liver will convert it into urea for excretion. But liver is not working well, you're not having this conversion, so ammonia just hangs out in your blood, builds up, causes problems in your brain. Okay, finally, decreased protein synthesis. So, normally your liver makes albumin. Not enough albumin, what does that mean? There's low albumin in your blood vessels. That's decreased oncotic pressure. Okay? Decreased oncotic pressure, what was that going to cause? That's going to cause blood fluid to go out of your blood vessels into the interstitium, and you're going to get edema. You're going to get decreased synthesis of clotting factors. What happens if you have less clotting factors? Well, then obviously you're going to bleed more, so you get bleeding and coagulopathy. Okay? And finally, you have something called hepatorenal syndrome. This is basically renal failure that results from various complications of cirrhosis. And I like this one because it synthesizes a lot of the problems that can arise from cirrhosis. Okay? What can cause decreased blood flow to the kidneys? Let's see. Will bleeding cause decreased blood flow to the kidney? Yes. You can, including in the esophageal varices, which is in the portosystemic shunts. So bleeding could cause decreased flow. Will edema cause decreased flow? Yes, because remember now you have less flow in the blood vessels because it's all going to the interstitium. So that can help cause hepatorenal syndrome. Other things that can cause this include include ascites, all this ascites fluid. Okay, all this fluid is stuff that's not going to the kidneys, so that can cause hepatorenal syndrome. And the other thing that causes it is hepatic encephalopathy. I'm going to talk about this in a second. The way you treat this is you treat this with a laxative. And it's going to make you poop, and a lot of fluid's going to go to your colon, so you're going to lose fluid there. So all of that is going to cause hepatorenal syndrome, basically acute renal failure, due to poor blood flow to the kidneys, and this is all arising from complications of cirrhosis. So I just told you I'll talk more about hepatic encephalopathy. Told you how it works. Liver normally turns your ammonia into urea for excretion. It doesn't happen because your liver is not working well. Ammonia causes altered mental status. You get hysterexis. The way you treat this is with lactulose. So what does lactulose do? How does that help? Lactulose is converted to lactic acid by gut bacteria. Okay, now there's going to be extra H plus in the gut. And that H plus is going to turn your ammonia, NH3, into ammonium, NH4 plus. NH4 plus is not very well absorbed in the bowel. So NH4 plus, ammonium, is excreted in feces, and then thus you have decreased NH3 in your blood. You decrease ammonium, problem solved. The other thing you can do is you can give a neomycin, that's an antibiotic, and that's going to kill off your ammonia producing bacteria in the gut. But lactulose is your number one. Remember that lactulose is basically sugar. You give them sugar. And this is also a very strong diuretic because you give them a high osmolar bolus into the gut, puts a lot of water into the gut, causes diarrhea. Next is spontaneous bacterial peritonitis. So that's inflammation in the peritoneum due to bacteria, and this is infection of the acidic fluid in the peritoneum. So you have all this acidic fluid, it just stagnant here. It's like a swamp again. So bacteria can grow in here, and it's going to cause overgrowth and infection. Symptoms here are very general. Pretty much you can kind of guess infectious symptoms. They're freaking bacterial infection. Then you have abdominal pain and ileus. It's because you have infection in your gut, infection just all around your intestines. So you're not going to have very good bowel function. You can have worsening of encephalopathy because you're having an infection is not going to help in a patient who has cirrhosis, who is already predisposed to having encephalopathy. And what you're going to do is you can put a needle in here. You can stick a needle in here. You can draw out some of that fluid and you analyze it. And if you see this more than 250 neutrophils in that acidic fluid per millimeter cubed, then that's going to tell you you have an infection in that peritoneal fluid because there's the neutrophils. Neutrophils telling you there's infection. Treat this with the third generation cephalosporin. Finally, I'm going to talk about liver and bile duct serum markers. These are markers that are going to tell us how much liver damage we have. So the first things we have are liver function tests. This is a misnomer because what they actually measure is liver damage. They don't measure liver function or how well the liver is actually functioning. These are enzymes that are released when your liver cells are damaged, and they're released from the liver cells or from the bile ducts. First is the ALT and AST. So first, ALT is alanine aminotransferase. AST is aspartate aminotransferase. Just forget it. It's called ALT AST. Okay. ALT is more specific than AST for liver damage because AST can be found in other organs as well. But ALT is specific for liver. Okay, L for liver. So normally, it kind of makes sense to me then that in most liver disease, ALT is higher than AST in liver damage. Characteristically though, in alcoholic liver disease, it's the opposite, okay? In alcoholic liver disease, AST is greater than ALT. So if you see AST greater than ALT, and then you know there's liver damage, and you know that damage is probably from alcohol, okay? So I remember normally it's ALT more than AST because ALT is more specific for the liver, but then alcoholic liver disease is the exception, although advanced cirrhosis can also have that. The other one we could look at is ALP, which is alkaline phosphatase, and GGT. Okay, these both can be elevated in cases of biliary disease. The reason why we check both of them is that alk phos can be found in other places such as bone. So if you have a bone disease, you're going to have elevated ALP as well. But however, in bone disease, GGT is not elevated. So that's why we measure both. If both are elevated, it's more likely that you have some biliary problem. Now I just told you these are called liver function tests above, but these mark liver damage. The real markers of liver function are what the liver actually does. So the liver normally helps. What does the liver do for bilirubin? Remember, the liver normally helps excrete bilirubin. So if you have cirrhosis, what's going to happen? If you're not excreting bilirubin in disease, let's go back. Disease, bilirubin goes up. What about albumin? Normally the liver, what does it do? Remember, albumin is a protein. Liver normally makes albumin. Okay, so if there's disease in the liver, what's going to happen to your albumin? Albumin is going to go down. And then again, you get decreased oncotic pressure leading to, is the problem? You get edema. Prothrombin time. Prothrombin time is a measure of clotting ability. So kind of like how long does it take for you to clot up? If you have less clotting ability, you have a longer prothrombin time. And your liver is normally responsible for making some clotting factors. So what's going to happen to your prothrombin time if you have liver disease? Your clotting time is going to go up. Your prothrombin time is going to go up because you have decreased clotting ability. Finally, platelet count. What does the liver do for platelets? Liver makes thrombopoietin, which stimulates platelet production. And when you have liver disease, you get sequestration of platelets in the liver and the spleen. Okay? So the sequestration, they're going to hang on the liver and the spleen. They're not going to be in the blood. So your blood levels of platelets, what's going to be? It's going to go down, okay? You don't even have to memorize this. Just understand what the liver does for each of these markers of liver function, and it's obvious. Okay, so that's it for cirrhosis and its complications as well as these markers of liver disease.